For years, you have heard a comforting line: drink some water and eat healthy. Food stones will not be a problem. I wish it were that simple. Kidney stones form when urine becomes concentrated and the balance of minerals shifts: too much oxalate, uric acid or calcium in the wrong chemistry, or too little citrate, the natural stone shield your body makes. Add extra salt, frequent animal protein, sugar-sweetened drinks, or cola high-dose vitamin C, certain medicines and chronic conditions, and the scales tip even faster. If you live with chronic kidney disease, your safety margin is smaller. A trendy detox or cleanse can quietly dehydrate you, pull down your blood pressure, and disturb electrolytes. That is not cleansing the kidneys, that is stressing them. Picture this. You powered through yard work on a hot afternoon, grabbed an ice-cold cola, skipped water, and woke at 2 a.m. with stabbing flank pain. The ER nurse handed you a strainer and pain medicine. A scan showed a stone, and suddenly the week's plans were rearranged by a few millimeters of rock. Here is my promise: you do not need a crash program. You need small, intelligent, repeatable moves that fit your real life. The question is not whether you are good or bad with food or fluids, it is whether your habits create friendlier urine chemistry. Which everyday habits quietly build stones and which simple moves protect your kidneys? Let us find out. Stones are crystals that grow in concentrated urine. Think about a glass of iced tea, add enough sugar, and it dissolves. Let the tea evaporate, and crystals appear on the bottom. The kidney version depends on what is in your urine: calcium, plus oxalate uric acid struvite, from infections, or cysteine, in rare inherited conditions. Citrate is your built-in helper. It grabs calcium and keeps it from forming crystals. After 60, several forces push in the wrong direction. Thirst signaling is weaker, so you simply do not feel like drinking. Many of us live with blood pressure, diabetes, or cholesterol issues and take multiple medicines. Some drugs shift urine pH, increase calcium or uric acid in the urine, or reduce citrate. Examples include certain diuretics, topiramate, high-dose vitamin C, and some antacids or supplements if used inappropriately. Metabolic syndrome and diabetes can lower urine pH, which favors uric acid stones. Here is the key: foods are not good or bad in isolation. Portion timing and the overall pattern, salt load, sugar intake, animal protein, and how much and when you drink decide your risk. If you have CKD, your clinician may limit fluids or potassium for safety. In that case, we target pale yellow urine within your prescribed limits and focus harder on sodium, sugar, and protein choices. You do not have to memorize chemistry. You need a short checklist and a few swaps that you repeat until they feel automatic. So how do we spot the biggest culprits and build stone-safe habits that actually fit your day? Here is the roadmap. We will walk through 9 everyday causes of stones and pair each one with a practical protection step. You will not do all 9 at once. You will pick 1 or 2 this week, then stack another next week. In one, low fluid or heavy sweating, concentrated urine, protection plan fluid like medicine. If you are not on a fluid restriction, aim for pale yellow urine and roughly 2.5 liters of output per day. Sip across the day, not all at once. Add a squeeze of lemon if your clinician allows. Citrate helps. 2, high sodium. Protection. Keep sodium under 200 to 300 milligrams a day unless your clinician sets a different target. Salty snacks, deli meats, canned soups, and restaurant sauces are the big hitters. Less sodium often means less urinary calcium and steadier blood pressure. 3, high oxalate without calcium at the meal. Protection pair, high oxalate foods, spinach, beets, coconuts, like almonds, with food-based calcium in the same meal. Calcium in the gut binds oxalate, so it exits in the stool, not the kidney. 4, too little dietary calcium. Protection. Unless your clinician says otherwise, target 1,000 to 1,200 milligrams each day from food, dairy, or fortified alternatives, which helps keep oxalate in the gut. This is different from taking random calcium pills. 5, heavy animal protein and purines. Protection favor moderate portions and add plant proteins. Too much animal protein raises uric acid and lowers citrate. 6, sugary beverages and cola. Protection. Replace sugary drinks with water, unsweetened tea, or diluted lemon water if allowed. Most cola contains phosphoric acid, a frequent troublemaker. 7, obesity, metabolic syndrome, diabetes. Protection, gentle, consistent weight loss and better glycemic control raise urine pH and reduce uric acid stone risk. 8 medicines and supplements. Protection: review your list with your clinician. Watch top pyramate high-dose vitamin C, certain diuretics, and mismatched calcium, vitamin D, or NSAIDs. Take phosphate binders exactly as prescribed if you use them. 9 recurrent UTIs, urinary retention, or anatomical issues. Protection: do not delay care for burning fever or flank pain. Struvite stones grow in infected stagnant urine. Expect friendly numbers and visuals ahead. Many patients feel fewer cramps, wake less at night, and see steadier labs within 4 to 12 weeks of consistent changes alongside medical care. Let us dive into the causes. What it is. Busy days, hot weather, exercise, travel, or simply forgetting to sip. Your body loses water and your urine becomes darker and denser. Dense urine is crystal friendly. It makes it easier for minerals to collide and stick. Why it matters in stones and CKD: concentrated urine raises the supersaturation of stone-forming particles. Calcium, oxalate, uric acid. When the solution is dense enough, crystals nucleate and grow. In CKD, the safety margin is smaller. Even modest dehydration can reduce kidney perfusion and disturb electrolytes, turning a mild day into a stone day. Evidence on numbers. If your clinician has not restricted fluids, aim for pale yellow urine and roughly 2.5 liters of urine output per day. Spread sipping across the day, not in a late chug. A squeeze of lemon or lime, if allowed, adds citrate, a natural inhibitor of calcium stone formation. Dark apple juice colored urine is a nudge to drink sooner. Patient snapshot. Mr. J, 67, a retired mail carrier who loves gardening. He worked through summer heat, cooled off with cola, and skipped water for hours. After a 2 a.m. stone attack, we set a simple sip schedule tied to his pill times and added lemon water 3 afternoons per week. 8 weeks later, he reported lighter urine most days, no night awakenings for pain, and steadier blood pressure. He kept 1 cola on Sundays and stayed comfortable. How to act. Make a fluid ladder, a dedicated sip after each bathroom break, during meds, before leaving the house, and with each meal. Use clear bottles with markings so you can see progress. Shift more sipping to morning and midday if nocturia bothers you. On hotter active days, plan extra sips and cool-down breaks. If you are fluid restricted, follow your exact prescription. Your goal is still pale yellow within that plan. Red flags and when to seek care. Inability to keep fluids down, minimal or no urine, severe flank pain. Fever with chills, chest pain, or near fainting, seek urgent care. Dehydration and stones can escalate quickly in older adults. What it is: salt sneaks in through processed foods, restaurant meals, deli meats, canned soups, sauces, and snack foods. You can avoid the shaker and still overshoot your day's sodium target. Why it matters in stones and CKD: sodium increases urinary calcium, supplying more building blocks for calcium-based stones. In CKD, high sodium also worsens blood pressure and fluid retention, stressing kidneys and the heart. Evidence: char numbers. A practical target is under 300 mg sodium per day unless your clinician sets a different goal. Trimming sodium commonly lowers systolic blood pressure by 3 per 5 mm chunks within 4-8 weeks, alongside other changes, and generally reduces urinary calcium. Label surprises: a reasonable handful of packaged nuts or seeds can hide 200 out to 300 mg sodium. Soups and sauces often deliver several hundred mg per serving. Patient snapshot: a 71-year-old with CKD stage 3 and evening ankle swelling, ate deli turkey most lunches and canned soup most nights. We swapped in no salt added beans and rinsed canned vegetables, moved sauces to on the side, and used citrus, garlic, and pepper for flavor. 6 weeks later, his home BP averaged 4 to 5 mg lower, and his 24-hour urine calcium dropped. Fewer cramps, better sleep. How to act: read labels. Choose no salt added products, rinse canned items, pick low sodium broths. In restaurants, ask for no added salt and sauces on the side. At home, season with herbs, citrus, vinegar, and pepper. Avoid flavored salt mixes that hide sodium and phosphate additives. Watch for foes. On labels: red flags and when to seek care. Rapid weight gain from fluid, worsening leg, swelling, shortness of breath, pounding headaches. Contact your clinician promptly. If you take ACI, ARB, spironolactone, lower sodium, helps these medicines work better. What it is: Oxalate occurs naturally in certain plants: spinach, beet, greens, rhubarb, almonds, peanuts, cocoa powder, and some bran cereals. Eating these in large portions or daily repetition without calcium at the same meal allows more oxalate to be absorbed and later excreted into urine. Why it matters in stones and CKD: most stones are calcium oxalate. In the gut, calcium binds oxalate and then escorts it out in stool. Without calcium present, oxalate slips through and raises urinary oxalate, a powerful promoter of crystals. In CKD, altered mineral balance and diet patterns can amplify the effect. Protecting the gut step becomes even more valuable. Evidence numbers. If not fluid restricted, keep urine pale yellow. Consistency matters more than streaks of perfection. Pair higher oxalate foods with food-based calcium dairy or appropriately fortified alternatives in the same meal. Many older adults do well targeting 1,200 millinosmers day of calcium from food unless instructed otherwise. Repeating large almond portions daily can raise oxalate exposure. Rotating nut choices and pairing with a calcium food helps. Patient snapshot. A 69-year-old switched to daily spinach smoothies and almond snacks for health and soon passed a stone. We kept his greens but moved to mixed greens, arugula, romaine kale. Most days kept spinach as a smaller side and paired higher oxalate choices with yogurt or fortified milk. 3 months later, he had no attacks and his urinary oxalate improved. How to act. Keep the plants, adjust the pairings and portions. Make spinach a side, not a bowl. Rotate greens. Keep cocoa portions small. Swap some almonds for pecans or macadamias in pre-portioned bags. If lactose is an issue, use lactose-free or fortified non-dairy options. If your clinician prescribes calcium or citrate for prevention, take them exactly as directed with meals. If you use phosphate binders for CKD mineral balance, they must be timed with meals that contain phosphorus to work well. Red flags and when to seek care. Severe flank pain, visible blood in urine, persistent vomiting, fever, seek urgent care. New numbness, weakness, or fast heartbeats with dietary changes deserves a call to your clinician. What it is. Avoiding calcium foods to prevent calcium stones sounds logical but backfires. Without dietary calcium in the gut, more oxalate is absorbed, raising urinary oxalate. Dietary calcium is a stone prevention tool when used correctly. Why it matters in stones and CKD: adequate food-based calcium binds oxalate in the intestines, lowering urinary oxalate and reducing calcium oxalate crystal formation. It also supports bone health, important for fall prevention and independence. In CKD, calcium balance is individualized. Decisions depend on labs, calcium, phosphorus, PTH, and your nephrology plan. Evidence, just numbers. Unless contraindicated, many older adults target 1,200 milligrams a day of calcium from food. This is not a green light for random calcium pills. Supplement use is tailored. The timing matters. Calcium should show up with higher oxalate foods. Patient snapshot. A 73-year-old with a history of stones cut out dairy entirely. We reintroduced small, tolerable servings, lactose-free milk at breakfast, yogurt at lunch, and paired them with the meals most likely to contain oxalate: greens, nuts, cocoa. 12 weeks later, urinary oxalate dropped and she felt steadier on her feet. How to act. Anchor 2 meals per day with calcium milk or fortified alternative at breakfast, yogurt at lunch, modest cheese at dinner. If lactose bothers you, choose lactose-free or non-dairy fortified options. Combine spinach omelet, add a small cheese portion, cocoa treat, pair with yogurt. Review vitamin D, calcium supplements, and phosphate binders with your nephrology team. Do not self-start high-dose supplements in CKD. Red flags and when to seek care. Constipation, confusion about doses, or signs of oversupplementation, call your clinician. Stone pain, fever, or vomiting is urgent. What it is: large portions of red meat, organ meats, and certain fish, anchovies, sardines, raise purines which metabolize into uric acid. High animal protein can also lower urine citrate, urinate stone shield, and make urine more acidic. Why it matters in stones and CKD: high uric acid promotes uric acid stones and can seed calcium stones. Protein acid load lowers urine citrate and can push urine pH downward, especially in metabolic syndrome or diabetes. In CKD, excessive protein can strain kidneys. Most patients do better with moderate protein tailored by their clinician or dietitian. Evidence adjust your numbers, keep portions, palm size for meats, add plant proteins you tolerate beans, lentils, tofu, peas according to your potassium plan. Better glucose and weight control raise urine pH and lower uric acid stone risk. Patient snapshot. A 70-year-old former athlete ate meat at every meal. We reframed dinner, make meat the side 3 nights per week, swap in bean and lean meat chili, and add a fish night. With steady hydration, his nighttime cramps eased, and he had no new stone events at 10 weeks. How to act. Plan meat as a side dinners. Choose poultry or fish more often. Limit organ meats. Try half and half recipes, half legumes, half lean meat. Hydrate with higher protein meals. Keep alcohol modest. Beer can raise uric acid. If you have gout or uric acid stones, medicines like allopurinol may help. Do not start or stop without medical direction. Red flags and when to seek care. New severe joint pain, sudden flank pain, dark or red urine, or persistent nausea, seek care. Lightheadedness or chest pain is an emergency. Before we continue, hit like and subscribe. I have linked a free one-page kidney stone prevention checklist below. Print it and keep it on your fridge. What it is: sugar-sweetened beverages, regular sodas, sweet teas, energy drinks, and especially cola, which often contains phosphoric acid, shift urine chemistry in stone-friendly ways. HFCS and big sugar loads spike insulin and uric acid production. Frequent sipping replaces water you need it. Why it matters in stones and CKD: high sugar intake raises uric acid, lowers urine pH, and may reduce citrate, a triple hit for stones. Phosphoric acid in many colas can alter mineral handling and acid load. In CKD, sugar-sweetened beverages worsen metabolic health and fluid balance, further stressing kidneys and blood pressure. Evidence numbers: replacing daily sugary drinks with water or unsweetened options often lowers weight, improves glucose control, and can reduce stone risk within weeks. People are surprised to learn a single large soda can displace 500 to 700 milliliters of water they would have otherwise sipped that day. Patient snapshot: a 68-year-old truck driver relied on 2 colas and sweet tea to stay alert. We set a weekday rule: swap soda for water or unsweetened tea. Keep one favorite sweet drink on Saturday. He added lemon water once daily and allowed by his clinician. 8 weeks later, he dropped 5 pounds, nocturia eased, and afternoon energy stabilized. How to act. Adopt a weekday swap: water, sparkling water, or unsweetened tea. If allowed, add a small squeeze of lemon for citrate. Keep a weekend treat if it helps you stick with the plan. Read labels for phosphoric acid and high sugar. Avoid detox drinks that cause diarrhea or dehydration. Red flags and when to seek care. If you develop severe cramps, palpitations, vomiting, or cannot maintain hydration, contact your clinician. For chest pain, shortness of breath, or fainting, emergency care. What it is: excess body fat around the abdomen, high blood pressure, high triglycerides, low HDL, impaired fasting glucose, and insulin resistance cluster as metabolic syndrome. Type 2 diabetes sits on the same spectrum. Why it matters in stones and CKD: insulin resistance lowers urine pH, favoring uric acid stones. It may also reduce citrate. Elevated uric acid and acid load promote crystals. CKD plus metabolic syndrome accelerates vascular and kidney stress, shrinking the buffer against dehydration or dietary slips. Evidence: chart numbers. Gentle, consistent weight loss. 5 to 10% of body weight over months improves insulin sensitivity, raises urine pH, and lowers uric acid. Even a single-point drop in A1C can reduce stone-promoting chemistry. Many patients report fewer cramps, lighter urine, and steadier sleep after 8 to 12 weeks of small, sustained changes. Patient snapshot: a 72-year-old with central obesity and prediabetes had 2 stones in 18 months. We added 10-minute after-meal walks, a half plate of non-starchy vegetables at lunch and dinner, and a weekday soda to water swap. At 12 weeks, he lost 9 pounds, blood pressure improved, and he had no stone symptoms. How to act: aim for slow, sustainable change. Half-plate vegetables, palm-sized lean protein, modest whole grains, and water as your default drink. Schedule short walks after meals to blunt glucose spikes. Sleep 7 to 8 hours when possible. Poor sleep raises insulin resistance and stone risk behaviors. Late salty snacks, extra sugary drinks. Red flags and when to seek care. Unintentional weight loss, profound fatigue, high fevers or severe flank pain warrant prompt evaluation. If blood sugars run high or low as you change diet and activity, call your clinician to safely adjust medications. What it is. Several medications and supplements can inadvertently nudge urine chemistry toward stones. Examples include topiramate, can raise urine pH and lower citrate. High-dose vitamin C converts to oxalate, some diuretics, and dehydrating agents mismatch calcium, vitamin D, or certain antacids and over-the-counter products that are not benign. On the other hand, specific meds, e.g. thiazide diuretics, allopurinol potassium citrate may be used to prevent stones. Why it matters in stones and CKD. In CKD, the kidney's ability to buffer shifts is reduced. A pill that is harmless in one person may tip another into stone-friendly chemistry or electrolyte problems. Polypharmacy and drug interactions complicate the picture. Evidence or numbers. Vitamin C high doses, especially 500, 1,000 nanomoles a day, can raise urinary oxalate in susceptible people. Topiramate alters acid-base balance. Stone risk rises in some users. Diuretics. Some increase calcium in urine. Others, thiazides, may reduce it. Your clinician chooses based on your profile. Binders. Phosphate binders only help when taken with phosphorus-containing meals. Patient snapshot. A 70-year-old started high-dose vitamin C for immunity and used an over-the-counter antacid daily. After a stone, we reviewed his meds. He discontinued excess vitamin C, switched to clinician-guided vitamin D and calcium from Food and Time binders with meals that actually contain phosphorus. 3 months later, he felt steadier with no recurrent pain. How to act. Bring all prescription and over-the-counter products to your visit, including supplements, powders, and natural remedies. Ask, how does this affect urine pH, citrate, calcium, oxalate, or dehydration? If you are prescribed potassium citrate, thiazides, or allopurinol, take them exactly as directed. If you must use antacids, ask which type and dose fit your CKD and stone profile. Avoid self-starting high-dose vitamin C, red flags and when to seek care. New palpitations, muscle weakness, severe cramps, or sudden urinary changes deserve attention. Call your clinician. For fever with flank pain, inability to urinate, or vomiting that prevents hydration, urgent care. What it is. Urine that stagnates because of recurrent urinary tract infections. UTIs, incomplete bladder emptying, EEG from prostate enlargement, neurogenic bladder catheters, or anatomical abnormalities, creates a breeding ground for bacteria. Certain bacteria produce urease, which changes urine chemistry and forms struvite stones that can grow rapidly. Stagnation also allows crystals to linger and enlarge. Why it matters in stones and CKD. Infection-related stones are not just painful, they are dangerous. They can grow fast, damage kidney tissue, and provoke sepsis. CKD further reduces your safety margin. Any infection can trigger a sharp decline. Retention raises bladder pressure, backs up urine, and worsens risk. In men untreated, BPH can silently drive both retention and infections. Evidence, your numbers. Early UTI treatment and complete bladder emptying are the two most powerful levers here. Simple habits: do not delay urination, hydrate steadily within your plan, and watch for fevers or flank pain. Reduce complications. After procedures or catheter use, infection vigilance for weeks matters. Patient snapshot. Mr. L, 64. He had recurrent UTIs and often held it while driving. Ultrasound showed incomplete bladder emptying from BPH. We coached time voiding every 2-3 hours, emphasized not to postpone urination, and arranged prompt testing at the first sign of burning or fever. His urologist adjusted BPH meds. 6 weeks later, he had no reinfections, flank discomfort faded, and sleep improved. How to act. Do not hold urine. Build bathroom breaks into your day. If you use a catheter, follow sterile technique and change schedules exactly. Report fever or new pain immediately. Discuss BPH symptoms, slow stream hesitancy, dribbling nocturia, and options, medications, procedures, so you empty more completely. Hydrate steadily within your CKD plan and avoid constipation, which can worsen bladder emptying. After any UTI, complete antibiotics as prescribed. Consider a follow-up urinalysis if advised. If stones are suspected, imaging may be needed. Struvitz stones often require procedural removal. Red flags and when to seek care: fever with chills, severe flank or bladder pain, visible blood in urine, vomiting, confusion, or inability to urinate, urgent or emergency care. Infection-related stones can escalate quickly. Do not wait it out at home. Tonight is not about perfection. It is about your next step. Choose one of these and make it automatic for 7 days. Set a sip schedule that fits your morning pills, lunch, and afternoon routine. Aim for pale yellow urine if you are not fluid restricted. Cut one salty habit deli meat at lunch, the soup you do not actually enjoy, or the nightly chips. Pair a high oxalate favorite with a calcium food in the same meal. Make meat the side on 2 dinners this week and add a plant protein you can live with. Swap cola on weekdays for water or unsweetened tea. Keep the weekend treat if that helps you stick with it. Red flags that deserve urgent care: chest pain, racing or irregular heartbeat, profound weakness, inability to urinate, fever with chills, severe flank pain or vomiting that prevents hydration. If you found even one idea helpful, tap like, subscribe, and tell me in the comments which single change you will try this week. Your tip may help someone sleep pain-free tonight.